Alterations in cognition and sensation. And now we're talking about the central and peripheral nervous system disorders. Increased intracranial pressure is something that we deal with when we have head injuries or brain tumors, etc. It causes acute central nervous system and peripheral nervous system disorders that can be potentially life-threatening. Chronic issues are mainly going to affect their quality of life. But when we have increased intracranial pressure or increased ICP, we see a dilation or constriction of cerebral blood vessels in response to changes in blood pressure, blood oxygen levels, and blood pH that maintains a constant and consistent tissue perfusion. So once again, causes of increased ICP include brain tumors or swelling or bleeding from head traumas, infectious and inflammatory disorders such as meningitis and encephalitis. What happens is we have impaired cellular activity with a temporary or permanent neurologic dysfunction, and this can lead to death. These clients have a decreasing level of consciousness, which is the early sign. It is going to be the first thing that we see with increased intracranial pressure. They can become stuporous, semi-comatose, comatose. They may just have confusion or restlessness or periodic disorientation. They may have a headache that's more severe in the morning. They develop what we call Cushing's triad, where we have a pulse rate that increases initially but then begins to decrease, a systolic blood pressure that rises with a widening pulse pressure, and an irregular respiratory rate. They develop Cheyne-Stokes respirations. We may also see vomiting, papilledema, decorticate or decerebral posturing. We diagnose with skull x-rays, CT scans, MRIs, a lumbar puncture, and cerebral angiography. We want to treat these by maintaining their blood pressure, preventing hypoxia, and ensuring cerebral perfusion. As we increase intracranial pressure, it decreases cerebral perfusion. It's cutting off the blood flow. We're going to reach these goals by elevating the head of the bed, administering isotonic normal saline, lactated ringers, or hypertonic saline solutions. We need to avoid hypotonic solutions and solutions that contain glucose because hypotonic and glucose solutions can increase ICP. We may give osmotic diuretics. These are indicated in the oliguric phase of acute renal failure to excrete toxic substances and to relieve intracranial pressure by decreasing cerebral edema. It is contraindicated with drug allergies or severe renal disease, pulmonary edema, and intracranial bleeding. Adverse effects of these osmotic diuretics would include convulsions, thrombophlebitis, and pulmonary congestion. This main drug that we administer as an osmotic diuretic is mannitol. We're also going to administer supplemental oxygen to keep their oxygen saturation at 95%. We want to maintain their head in midline with at least 30 degrees of elevation. We're going to avoid hypothermia, control seizures by administering drugs such as diazepam, We're going to sedate agitated clients with drugs like midazolam, uh, because hyperactivity can contribute to transient rises in ICP. And we may put in an indwelling catheter, an NG tube, a stool softener, administer those histamine antagonists, or famotidine. A mnemonic to help you remember what goes on with increased ICP. Another mnemonic. So, which of the following nursing interventions are going to help prevent further increases in intracranial pressure? B, elevating the head of the bed. Remember, with increased intracranial pressure, we may have a lot of swelling going on, and elevation helps reduce swelling. Some of the neuromuscular disorders include multiple sclerosis, which is a demyelinating disease. It causes permanent degeneration and destruction of that myelin sheath that interrupts the nerve impulse transmission sheath. It occurs in clients that are young to middle age. It is considered to be an autoimmune disease. These clients may experience blurred vision, diplopia, nystagmus, weakness, clumsiness, and numbness or tingling of an arm or a leg, a tremor, slurred, hesitant speech, or mood swings. We may also see motor incoordination, bowel and bladder incontinence, loss of memory, difficulty with concentration, and impaired judgment. These clients also may experience pneumonia because of decreased mobility, and this is usually the cause of death. We diagnose with a lumbar puncture and CSF analysis, and we can also do electrophoresis of the cerebrospinal fluid. There is no cure for MS, but the treatment goal is going to keep the client as functional to keep them functional as long as possible. There are some drugs that we can administer, such as immunomodulators, that actually alter the immune response by enhancing or restoring the immune system. It does create a toxic effect on a tumor, or it modifies the function of this nerve impulse. We can use interferons, which treat certain viral infections, some cancers, and some autoimmune disorders. It is, of course, contraindicated with drug allergy or some of the autoimmune disorders. Contraindicated with hepatitis or liver disease or failure, or concurrent use of immunosuppressants. Adverse effects will include the flu-like symptoms. Fatigue is the major effect, and it does interact with zidovudine, or because it enhances the effect of that drug, and it also interacts with drugs that are metabolized in the liver. Other immunosuppressants are going to work by altering the immune response through suppression of the T lymphocytes. This can include glucocorticoids, calcineurin inhibitors, antimetabolites, and biologics. They are indicated with the prevention of organ rejection. It can reduce the exacerbation of MS and can calm inflammation. Contraindicated with allergies, with renal or hepatic failure, hypertension, or a concurrent radiation therapy. Adverse effects include an increased risk for opportunistic infections, an increased risk for some cancers, and post-transplant diabetes mellitus. We need to avoid live vaccines when we're administering these steroids or other immunosuppressants. It can interact with several things, such as grapefruit, foods that are high in potassium or fats, St. John's wort, cat's claw, and echinacea. Multiple drugs. Yeah, there's quite a few it interacts with. Another drug that we can administer for MS is glatiramer acetate that's used to treat specifically multiple sclerosis, contraindicated with allergy, and adverse effects include headache, hepatotoxicity, flu-like symptoms, back pain, AV block, bradycardia, hypertension, and edema. So as nurses and clients that have MS, we need to make sure that we're providing rest periods, elevating the head of the bed, suctioning secretions, being very patient and empathetic to help the client deal with his or her changes in their appearance, their function, and their lifestyle. Myasthenia gravis is a disease process that involves neuromuscular disorder that's characterized by severe weakness of one or more groups of skeletal muscles. The antibodies are going to bind to and degrade the acetylcholine receptors on the surface of skeletal muscles. It is a disease process that occurs more often in women than men. These clients experience that muscle weakness. They may have ptosis of the eyelid, in other words, where the eyelid does not function appropriately. They have difficulty chewing and swallowing. They may have diplopia, voice weakness, a mask-like facial expression, weakness of the extremities and the respiratory system. These clients can be diagnosed through IV administration of idrophonium or tinsolin. Excuse me. When we administer this medication, we have a very quick, rapid, but very brief relief of the symptoms. It does relieve muscular weakness in a few seconds, and the restored muscle strength will dissipate within minutes of administration. We can also do an acetylcholine receptor antibody titer. Chest x-ray can show enlargement of the thymus. And we can do an electromyography, which measures the electrical potential of the muscles. We treat it by giving anticholinesterase drugs, pyridostigmine bromide. We can give prednisone or immunosuppressants. We can also do a plasmapheresis where we remove the plasma, and very much like a dialysis machine, but we're removing plasma. We're going to filter out some of those bad cells and then reinfuse. We can also do surgical management by removing the thymus gland. Parkinson's disease is exhibited by a deficiency of the neurotransmitter dopamine. It has an unknown cause, but it can be due to exposures to environmental toxins such as insecticides, herbicides, or self-administration of illegal synthetic forms of heroin called MT or MPTP, or it can be from multiple head injuries or encephalitis. We do have a category of antipsychotic drugs such as phenothiazines that can produce a pseudo-Parkinsonism symptoms. So in other words, if clients are taking these particular antipsychotic drugs, it can look like they have Parkinson's and they really don't. So clients that do have Parkinson's will exhibit stiffness or rigidity. They'll have tremors or what we call the pill rolling with their hand, bradykinesia, which is going to be very slow movements, that mask-like expression, stooped posture, hypophonia, where they have a very low volume to their speech, a shuffling gait, and difficulty redirecting their forward motion. They may also have some drooling. We diagnose based on typical symptoms and neurological examinations. There's really no specific test for Parkinson. We're going to treat it with different drugs. The goal is going to be to prolong independence, and it's very important to instruct these clients on the importance of maintaining their medication schedule. The main medications that we're going to administer to these clients are going to be our dopaminergics, which are indicated to restore dopaminergic activity in Parkinson's disease. It is contraindicated in angle closure glaucoma and undiagnosed skin conditions. Adverse effects are going to include cardiac dysrhythmias, hypotension, chorea, muscle cramps, and GI distress. It does interact with pyridoxine, benzodiazepines, and other antipsychotic drugs. The main drug is going to be carbidopa levodopa. These clients are also going to receive physical therapy and occupational therapy, client and family education, and nutritional counseling. There is what we call a stereotaxic pallidotomy, which is a surgical management. It provides some deep brain stimulation. We can do gene therapy or glial cell-derived neurotrophic factor to help relieve some of the symptoms of Parkinson's. So which nursing interventions can help prevent falls in a client that has Parkinson's disease? Select all that apply. It's going to be A, keep the client's call light within reach. C, avoiding the use of throw rugs, because remember that can trip people up. Maintaining the client's bed in a low position, so when they do get out of bed and potentially have a fall, then less chance of injury. And providing a cane or walker for ambulation. So brain tumors are going to be classified according to whether they're benign or malignant, the type of cells that are involved, and the site of the tumor. Brain tumors can result in death whether they're benign or malignant because of pressure in particular areas of the brain and increased ICP. You know, the skull is a limited area, so the growth of a tumor, whether it's benign or malignant, can put pressure on areas of the brain and increase that ICP. Causes of tumors are unknown, may be due to a viral infection, exposure to radiation, head trauma, or immunosuppression, or it can be a metastasized site from somewhere else in the body. These clients, the most common is going to be a headache. This is more common in the morning and becomes increasingly severe. and occurs more frequently as that tumor gets bigger. Excuse me. They may have vomiting without nausea or without warning, papilla edema, seizures, speech difficulty, paralysis, and double vision. They may have a CT scan, MRI, or brain scan, or cerebral angiography to diagnose. We're going to treat it with surgery, radiation, or chemotherapy. We can also do intra-arterial or intrathecal administration with corticosteroids, osmotic diuretics. We're going to administer analgesics, anticonvulsants, and antibiotics if necessary. Surgically, we can do that craniotomy, craniectomy. We can inject radioisotopes or do the gamma knife radiosurgery. Nurses need to support adverse effects of the chemo and radiation and teach them about their medication, appointments, nutritional support, home care, rehabilitation, and help with any referrals.